back to the basic implant course here. So, so we get Mish. He's passed away. It's one of the four founders of dental implantology. Basically, he classified the bone density into four different types of bones. You have the D1, D2, D3, D4. D1 bone is very, very dense bone. D2 bone is a little bit dense bone, and D3 bone obviously is a little bit less dense bone, and then D4 bone is like very soft bone, basically. So there's a bit of a difference. Like D1 bone has very little cancellous bone, basically. So it's a lot more cortical bone. Cortical bone is like white bone. So if you ever lay a flap and you irrigate the bone out, right, with some sterile water and you suction it up, you'll see it's kind of white. It's just very white. And so you know the cortical bone is there. That's cortical bone. And when you first drill, like for your osteotomy, when you create into it, it feels very hard. It's solid. It's very solid. So it's good. It creates good stability over implants. And then the softer bone, which is like the cancellous bone, it's more porous, okay? And there's different types of porosities within the cancellous bone, basically. That's what makes the bone types different from D2, D3, D4, basically. So D2 bone has more, it's more denser as far as that trabecular pattern versus like the D3 gets less dense and then D4 is almost like just empty space. So that's why you want to be, you have to know what type of bone it is, number one. And CBCT is very critical because you can see some of the trabecular patterns within the bone on a CBCT scan. So once again, it's from a wood, like, comparison to a wood, like dense bone is like cortical D1 bone is more like oak or maple wood, if you guys are into woods, whatever. D2 bone is more like white pine or spruce wood. And D3 bone is like balsa wood. It's softer. It's like pretty soft. And D4 bone literally is like styrofoam. It's very soft. I mean, it's super soft. So, and this is how this is another classification. They call it the Hausfield scale, basically. And so the D1 bone is very little bit of cancellous bone, so it's a lot more denser. So there's some advantages and disadvantages to each of the bones, basically. So D1 bone is super dense. So like having super dense bone is always not the best because you have to remember your vascularity is within this. Within this area is where the vascularity is, right? And so, and in our body, our body's ability to heal is all dependent upon the vascularity. So when you cut somebody open, you bleed. And the reason why we bleed is because as we bleed, it creates all these, it releases the cytokines, all these stuff. And as it bleeds, you form a clot, and that clot is what helps you heal. That's the reason why PRP, all this stuff was invented, because, and we spin it down to try and create those growth factors to help stimulate healing in that area up there, basically. But if they don't bleed, it also doesn't, they don't heal. So like on the lower jaw, if we ever need to do any kind of GBR techniques or like where we do guided bone regeneration or anything like that, you have to sometimes decorticate the bone. You have to create these holes in the bone to create these bleeding points because it doesn't bleed. And so the bone doesn't just, when you graft it, it doesn't heal as well, basically. So that's the difference, like, in the types of, when you have too much cortical bone, it's also not the best, basically. So it's always a balance, right, between what's good, what's the best and what's not the best, right? So D1 bone has the greatest like bone to implant contact. Yes, it's very strong. And so if you do mini implants or anything like that, like on the lower anterior mandible, sometimes like the mini implants just like one drill, one tiny skinny drill, and then you drive the fixture in, okay? And as you're driving the fixture in, it's tapping into the bone. But so for instance, I had a case where I was doing a mini implant. Bone was so dense that the implant stopped driving. And then so if you need to back up if that happens, right? And if you try and force it, what happens? What happened in my case, the implant driver and the implant head, where it's like a hex head that fits on the mini implant, right? Because these are like one piece, either ball, whatever it is, it got damaged. And the implant wouldn't back up, it wouldn't. So I had to trephine, I had to trough around the implant to get that mini implant out, basically. And then I ended up placing a regular implant. But anyways, that's how dense the bone is sometimes in these type of D1 bones. So but also, it also not as vascular, so it doesn't heal as quick. You think that it's good because you have good stability of your implant. You think that, oh, it's awesome, my implant's like super stable. It's like 80 Newton centimeters, it's great, but no, it's not always the best. It's not always the best. So in osteotomy, sometimes we have to over enlarge the osteotomy. So that's why they have these for cortical bone, they have these separate extra drill to enlarge the cortical plate, basically, for that purpose. So D2 bone is actually the best bone. D2 bone, because you have a nice balance between cortical plate, a good cortical bone, and good balance of cancellous bone, where you have nice, thick thick, dense trabecular patterns. And usually D1 bone is in the anterior mandible, D2 bone is sometimes in the anterior mandible, mostly posterior mandible, sometimes the upper maxilla, anterior maxilla, that is. And it has a lot of vascularity, so it's good. Our implants get nice and stable, and it induces bleeding, and so that's good. So it helps to heal that implant, basically. It creates that osseointegration, which helps the implant to heal, basically. So D3 bone has a lot of vascularity, a lot more vascularity, but unfortunately, the cortical plate is thinner, number one, and then so it's not as strong. But it's not bad. So a lot of the posterior maxillas, like, sometimes even in the posterior mandible, sometimes you have D3 bone or whatever. And so you'd be surprised how many patients in the posterior mandible have mandible. You think mandibular jaw is hard, right? But they have D3 bone or even D4 bone in the posterior mandible. Like, you'd be surprised because all they have is just a very dense cortical plate, and the rest after that is the empty space there, basically. The trabecular pattern is hardly not present there. And so you think that the lower mandible, you're safe, but sometimes you can have dropped implants in the mandible because of this factor. And so you have to be very cognizant. This is why CBCT data is so important. You have to study and examine the CBCT before getting into your surgery, because you don't realize it, but you think that the bone is strong, and you just kind of do your osteotomy and just place the implant, and then the implant drops and it just disappears, and you're like, what the heck happened? And this is why. Some of this reasons is why. This is why this happens, basically. So D3 bone, so a lot of times, when you have this data, we under osteotomize the site, number one. And then when we place the implant, we place a bigger implant than the actual hole. The actual implant protocols, the systems, the drilling sequence is designed to under osteotomize the hole, number one. But we even under osteotomize even more, basically, on D3 bone or D4 bone, so that the implant creates the stability as it's driving it in, basically. So. And once again, D4 bone is like a styrofoam, so you have to really under osteotomize the site, and so you have to be careful with D4 bone because of how soft it is. And so the way how the maxilla resorbs with time, it's this is the way how we lose bone, basically. It's in an upward motion on the maxilla and inward motion. So the jaw bone kind of goes up like this, and then inward like this. And then the lower jaw, it's a little bit different. It actually goes down and outward. So we get, unfortunately, because of this, when the patients lose their bone, like that witch that I was talking to you about, the upper jaw kind of collapses right inward, and the lower jaw kind of comes up a little bit, so they become pronectic. Like they look like they're serial class 3s, even though they're not class 3s at all, basically. That's why it looks like that. So, and they've done some studies, and so remember the upper dentures have like the palate, but there's more surface area, right? So it's a greater surface area where it sits on, and because of that, it has more square inches of space where it puts pressure on the bone. And since the teeth are missing, it creates more pressure.